Our next speaker is Dr. Jude Damodaran. She is a consultant with the Child and the consultant with CAMHS in Lindadara in Kildare, Wicklow. She has over 10 years experience as a consultant, and she's worked in Beach Park Services and in Tala in the past. She's provided psychiatric care to children with neurodevelopmental disorders and complex genetic syndromes. So I will pass you over to her now.
Thanks for the introduction. So how many of you have asked children and young people to talk about their mental health problems and get help early if they're not feeling the best? I'm sure a number of you have done that. What if those children are non-verbal? What if those children don't understand what they're feeling? What if they can't explain? That is children with intellectual disability are facing on a day-to-day basis. Today I'm going to touch upon mental health problems in intellectual disability and give you an introduction to CAMHS ID services. So I'll go through the basics of intellectual disability just to set the scene and talk about mental health problems and the policy context and CAMHS ID service, and I'll touch upon the referral process to CAMHS. So some basic definitions. The WHO defines intellectual disability as the significant reduced ability to understand new or complex information and to learn and apply new skills. This means the brain's ability to receive, process, analyze, and store information is impaired in ID. Global developmental delay is the terminology used under 5 years of age when the severity cannot be determined. There is the WHO classification of intellectual disability, which is based on IQ score, which is obtained by standardized testing, as many of you would know. Mild ID is with an IQ score between 50 and 70. Moderate ID is IQ score between 35 and 50. Severe ID 20 to 5, and profound ID is under 20. In the new DSM-5 and ICD-11 hasn't been published yet for wider use. The terminology is going to change. We are going to be talking about intellectual developmental disorders, and it is defined by 3 core criteria. Low intellectual ability, usually defined as an IQ of less than 70, significant impairment of social and adaptive functioning, and onset in childhood. The severity of deficit in terms of adaptive functioning is usually determined by various tests which psychologists and other clinicians undertake, and it has to be addressed on 3 domains: social, practical, and conceptual domains. Practical domains would be activities of daily living. Social domains would be social communication difficulties, peer relationships, friendships, etc. And conceptual domains will be around the areas of memory, intelligence, processing speed, etc. So a little bit about the causes of ID. Often, in nearly 75% of cases, the cause of ID is unknown. It could be environmental factors, it could be genetic factors, but ID often runs in families. Of the known causes, Fragile X syndrome is the most common inherited cause of learning difficulties, and trisomy 21 or Down syndrome is the most common cause. Other causes include behavioral phenotypes with genetic or chromosomal etiology. This would be your Angelman syndrome, Cornelia de Lange syndrome, Prader-Willi syndrome, etc. The other known causes may include anomalies in the developing brain due to illness or injury. For example, meningitis in early childhood or infancy, fetal exposure to drugs or alcohol, oxygen deprivation during birth, premature labor, head injury, malnutrition, and toxic exposure, example lead. It is said that low birth weight is the single best predictor of learning difficulties, whether it is generic learning difficulty or specific learning difficulty. So So let's talk about some figures here. It is well recognized that children with intellectual disability have a higher incidence of mental health problems. Unfortunately, we don't have any Irish studies to give us figures. In 2007, in the United Kingdom, Emerson found that prevalence of psychiatric disorders was 36% among children with ID, when you compare it to 8% among children without ID. Children with ID also accounted for about 14% of all children with a diagnosable psychiatric disorder. Increased prevalence was marked for ASD or autism spectrum disorder, hyperkinesia, and conduct disorders. And I presume this is very likely to be replicated in the Irish population. In the Irish census of 2016, over 66,000 people, which represents about 1.4% of the population, was described as having an intellectual disability. The figures from the IDD register, the national register, would be slightly different. I think it is a conservative figure, as it can be up to 5% in some studies. Out of this, 24,000 people were under the age of 19. So roughly about 30 to 40% of people with ID are children and young people. So mental health problems in ID. There are many underlying factors that may contribute to the development of mental health problems for children with ID. This includes severity of their ID. The more the nature of severe the ID is, the more likely they develop mental health problems. The cause of their intellectual disabilities. For example, behavioral phenotypes present with behavioral difficulties and mental health problems within themselves. Then there are other biological factors such as pain, physical ill health, polypharmacy. Polypharmacy means often children with ID have received treatment with epilepsy, anti-epileptic drugs, and that can lead to mental health problems and behavioral problems. Psychological factors such as abuse and neglect, social factors, poverty, life events, poverty of social environment, stigma, all of these, including developmental factors such as affect dysregulation and attentional control, may lead to mental health problems. Children with ID also experience trauma. There is a high rate of abuse and neglect, bullying, family stress often leading to family violence, abandonment and isolation, institutionalization, etc. in children with ID. When we are faced with a problem in ID, when the child presents with difficulties, we often ask, what is wrong with you, rather than what is happening to you. How what is happening is affecting you. It is important to remember that they can be traumatized. They also want to feel safe, strive for meaningful relationships, and feel empowered, even though they may not have the words. Behaviors that challenge, for example, aggressive behavior directed at either their parents or siblings or peers, and self-injurious behaviors often causes a huge amount of upset in the people around them, and this calls for immediate intervention. And then the focus becomes the behavior rather than looking at what is actually happening. We should be looking at other factors in this case, looking at environmental factors, what has changed in their environment. Whether it is a manifestation of epilepsy or some drugs some medication they are taking, or is there an underlying physical cause? Some of the challenges in identifying mental health problems, often they are undetected and symptoms can be lost among the plethora of behaviors. They are often comorbid with epilepsy, other physical health problems, sensory impairments, and it is important to consider these problems in both the diagnosis and management. Children with ID may be unable to complain of, like I said in the beginning, or describe their symptoms or distress, and their symptoms may be inadvertently attributed to their learning disability. They may have unusual presentations of symptoms the more severe the nature of their ID. And diagnostic delay leads to problems over time, and that can influence outcome. For example, trauma leads to increased cortisol levels in the brain, which is a stress hormone, and that in itself can lead to a lot of difficulties in the child, both physical and mental health wise. Management of mental health problems. The most common intervention used to manage mental health problems in children or people with ID is psychotropic medication. We don't have much child data. These are based on adult data, even though medication has very little effectiveness. The safety of medication is not well tested in this group because often these children and adults are excluded from clinical trials, and they are very sensitive to medications and their side effects. That is due to the nature of their neurodisability and the neuronal susceptibility to the various side effects. Having said all of that, about 50% of adults with intellectual disability are prescribed psychotropic medication. 20 to 25% receive antipsychotics with a lot of side effects, and 12% are on antidepressants. A large proportion receive mood stabilizing drugs for the treatment of their epilepsy. Around 16 to 50% exhibit aggression or challenging behavior, and up to a third of these cohort are prescribed psychotropic medication. It's more commonly prescribed in young males with severe cognitive impairment. The next most commonly used is psychosocial intervention. However, the therapies are not standardized in this group, and they have to be tailored, and there is limited expertise in the delivery of psychosocial intervention, even though it is very important to consider this alongside medication or even before medication. The Irish mental health policy, as you all know, outlined in the Vision for Change, emphasizes the importance of MDT, multidisciplinary teams, in delivering mental health services to the whole population, including children with ID. And you can see the breakdown of the teams, and they have also recommended the development of acute beds and day hospital services for mental health and intellectual disability treatment. We have moved on from Vision for Change. Now we have published Sharing the Vision document. Where are we now in terms of service provision? A phased resource plan is in place to develop at least baseline teams involving a consultant psychiatrist, clinical nurse specialist, psychologist, and admin support where there is no existing team, and to augment the existing teams where they are present. And there is also talk about innovative services which might include therapeutic respite for children with ID and significant mental health and behavior support needs. That would, I'm cognizant of the question that came earlier. In that scenario, that child might have benefited from therapeutic respite if it was available to that family, and the parents would have been able to care for the child at home going forward. There are 15 teams required as per Vision for Change, 1 per 300,000 population. There are a small number of professionals, mainly psychiatrists, working at CHO level. However, there are also areas with no dedicated service for children with intellectual disability. In CHO 7, which is Kildare, Beswicklow and Dublin, we have one team with 2.6 whole-time equivalents based in Cherry Orchard campus, and one team with 1.4 whole-time equivalents based in Kildare town, covering Kildare, Beswicklow. So that is it. And the national coverage for Vision for Change for CAMHS ID is currently running at 14%. CAMHS ID team, as you know, it's like a generic CAMHS team. It's a specialist mental health team which aims to complement the services provided by primary care and disability network teams for limited periods of time. It's recovery oriented, and the plan is always to discharge back to primary care or disability network teams. And children should continue to access the supports through their disability network team, because the CAMHS ID teams are not staffed to provide all the things they need like SLT, OT, etc. Specifically, the team provides diagnosis and treatment of mental illness, moderate to severe, which significantly impacts on the day-to-day functioning of the child. And the CAMHS ID team do not have access to educational into other education, special education, or respite or residential services. We do have an advocacy role. Progressing disabilities for children and young people. It's a national program, and under that there are children's disability network teams. In Kildare, we are way ahead in terms of the network disability teams. There are in fact 3 teams in the county, and the aim of this is to provide equitable and consistent services for all children with disabilities. And it would be best practice for intervention to be provided initially by the network disability team prior to referral to CAMHS ID team. Referral criteria. Referrals are considered when there is an evidence or suspicion of moderate to severe mental illness or disorder before the age of 18, living in the catchment area with level of ID in the moderate to severe to profound range. Children within the mild ID range falls within the remit of CAMHS service. In order to understand the level of ID, all referrals should include a comprehensive cognitive and adaptive behavior assessment completed by a psychologist with experience in neurodevelopmental disabilities, preferably in the previous 3 years. We are not going to turn down referrals of a 15-year-old who had a psychological assessment at the age of 10 or 9, for example. All referrals should be accompanied by a GP or a pediatrician referral because medical complications, medical issues can present as behaviors and mental illness in children with ID. They may also affect our treatment choices. It is important for us to get that medical referral in. And sometimes simple things as dental pain may cause mental behavioral challenges for children. Sometimes referrals are not accepted if the primary presentation is just autism or ID. And also sometimes we look at intervention provided by the disability team. If there has been no intervention, we would direct them back to the network disability team. And the pathway, I said, is through GPs. And if another professional, for example, wants to make a referral, they need to get involved, their GP involved. A completed referral form and a referral letter from the GP is sought at the time of referral. If not already furnished a psychological assessment, we'd look for that and other reports, for example, positive behavior support plan. When a referral is not accepted, it will be the referral agent will be advised in writing, giving clear justification and signposting to appropriate services. Let me finish by this quote. You treat a disease, you win, you lose. You treat a person, I guarantee you, you will, no matter what the outcome. It's a quote by Patch Adams. I think it is very poignant in children with ID and mental health difficulties. It opens our thinking to holistic approach and the importance of psychosocial interventions along with medication in children with ID and mental health. I have some references here, and I'd be open to questions. So it has been increasingly difficult to have genetic testing carried out for ID and mental health issues within public pediatric services. Would your advice? Okay, genetic testing is done usually through Crumlin Hospital. So if you can contact the child's general practitioner to send a referral to the GP, through the GP to the genetic in Crumlin. It is, I can't get the name of the consultant there, but it is the genetic services in Crumlin. And in my experience, it is done maybe through the GP or the pediatrician. I hope that answers the question. Okay. Nasty mentioned toxic exposure. Is there a link between tap water and lead studies being undertaken? Yes, lead exposure, especially, I don't think in the new building regulations people use lead in pipes anymore, but in olden days, in the 50s and 60s, I think a lot of the pipes were made of lead and there was toxic exposure. And there are studies worldwide proving lead exposure and anemia and mental health difficulties and intellectual disabilities. Yes, yeah. Okay. Okay, thank you very much.